So somebody wanted to know about stroke in the occipital cortex and how to make the diagnosis and what are the pitfalls. And the reason it's important to know this is the most common cause of bilateral simultaneous vision loss in a hemionopic pattern is actually occipital cortex infarct in an older patient, especially if they have vasculopathic risk factors. So stroke should be the top of the list. And even though it seems like it'd be obvious that it is bilateral and simultaneous and a homonymous hemianopsia, the patients often don't notice the nasal field defect. So they only complain about the temporal field defect. And so they might say it's unilateral when it's not. And they might not recognize the hemianopic character of it. So it's super important that you test the visual field in any patient who has unexplained vision loss. And of course, the acuity in the patient is going to be 20/20, 6/6, because the half a macula still sees 20/20. There's going to be no pupil abnormality because it's behind the afferent pupillary pathway, and the fundus is going to be normal. And so this is going to have a normal structural eye examination. And so in a 74-year-old who's complaining about blurred vision, you might find something like a cataract or AMD and think that's the cause when in reality they've had a stroke. So we need to do a formal visual field, like a Humphrey visual field. You're going to do a confrontation field as well, but probably you should do automated perimetry because confrontation fields are not very sensitive to the detection of field defects. And the homonymous hemianopsia that from the occipital cortex has some differentiating features that you do need to know about. One of those features is macular sparing. And so when we say macular sparing, that means the field is spared. The acuity is 20/20 regardless of whether it's macular splitting or macular sparing. Half a macula still sees 20/20. And so this finding of this macular sparing is an occipital finding because a lot of effort's been devoted, both a dual blood supply and a large amount of territory, to that central 5 degrees in the field. The second thing is it's going to be very congruous. And congruous means it's exactly the same in both eyes. And so when we have a very congruous field, that means you can cut this one out and paste it on the other side. So congruity and macular sparing are two features that suggest it's occipital. The last feature that you need to know about is the temporal crescent. So even though the majority of your field in the cortex is actually homonymous, there's one side and the other side are the same. That's what homonymous means. And because the field is actually an oval, not a circle, the nasal portion of the field is not as big as the temporal portion. The temporal portion has more field representation. And so even if you have a homonymous hemianopsia, the temporal crescent is bigger in the temporal field loss eye. And that temporal crescent, either sparing or involvement, is an occipital lobe lesion. So any elderly person or vasculopath with acute bilateral vision loss with a homonymous hemianopsia, you'd like to know which side it's on, because the lesion is going to be on the contralateral side. You'd like to know about macular sparing versus macular splitting, congruity, sparing or involvement of temporal crescent. And these are the features of the occipital stroke. You need to do a visual field on any of these patients that has unexplained vision loss.